Hi, everyone. Welcome back to Clinician's Brief, the podcast, where we get to have the conversations behind our clinical content. I'm the host of this program, Dr. Alyssa Watson, and today we're going to be discussing a topic that small animal practitioners like myself encounter on a regular basis. And that's how are we choosing the most appropriate therapy among all of the many different ophthalmic preparations that are out there. I know for me, when I walk into a clinic, the shelf the pharmacy shelf is usually stocked with a bunch of different drops, ointments, solutions, all of those things. And sometimes choosing, I haven't really stepped back and looked at kind of my thought process behind why I choose those medications. And that's what we're going to be doing today. So I'm really excited. Joining us is Dr. Shannon Boveland. She is a board certified veterinary ophthalmologist. She's a clinical professor at Auburn University. And she authored a quiz for Clinician's Brief recently that kind of walks through these real world scenarios involving this drug selection. So, Dr. Boveland, thank you for joining us. How are you doing today?
I'm good. Thank you, Alyssa, for having me. I'm very excited to be here today.
Yeah, we are so excited. I loved this quiz, and I will tell you, I actually even I was waiting and waiting for it to get published. So that I could send it over to a good friend of mine because we were actually having a conversation about ketorolac and when, to use that. And I was like, oh, you have to read this. I'm going to send it over to you as soon as it's ready. But I'm excited to have this conversation too. Before we do, though, would you mind just letting our audience know a little bit about yourself? Give us just a quick little bio.
Sure. I am a clinical faculty professor at Auburn University. I've been there since 2017. I earned my DVM in 2000 from Tuskegee University, which is just 15 miles down the road from Auburn. So kind of stayed in the Alabama area. During my residency, I did my residency at the University of Georgia. I completed a residency as well as a master's in ocular pathology. So I do have a little bit of background in ocular path as well. And once I completed my residency, I actually went back to Tuskegee and I taught there for several years until I moved to Auburn. So I've been at Auburn ever since.
That's wonderful. I have just a kind of tangential connection to Auburn. One of my really, really good friends from vet school did a surgical residency there. And I know that he just absolutely loved it. So that was a long time ago. That was like 2004. So let's go ahead and talk, as I said, like I'm sure everybody at home, my shelf just has 5, 6, sometimes 7 different types of ophthalmic preparations. Sometimes they go on back order and
Mhm.
we're looking for things, to fill the gaps. So can you just review the most common types of like solutions, suspensions, and ointments and what's really the difference between them in terms of formulation and how the drug is delivered to the ocular surface?
Sure, absolutely. Solutions and suspensions are commonly grouped together as eye drops. They're sterile in preparation, but there are some subtle differences between the two. Solutions are the drug within the solution is completely dissolved within the vehicle, whatever that vehicle is. And so therefore it makes the drug readily available when it's applied to the eye. Solutions tend to be transparent, and so they're readily absorbed. But because of that, they provide a much shorter duration of action. Your suspensions, the drugs within those, they exist as undissolved solid particles, and so they're dispersed within the vehicles, and so therefore those medications tend to have a cloudy or opaque appearance to them, and they usually require shaking prior to application. So a good example would be the use of topical prednisolone acetate, which the instructions tell you to shake, as well as compounding drugs that are produced by compounding pharmacies. A lot of those drugs are in a suspension form, and so they do require some shaking before application. Um, because these drugs have a larger particle, they dissolve more slowly within the suspensions, and so they provide a longer duration of action compared to solutions when they're applied to the ocular surface. Um, and so that's kind of like the differences, subtle differences between solutions and suspensions. Your ointments, those are your semi-solid, and the drugs are not completely dissolved. In most cases, the drugs are not completely dissolved within the ointment base, and it's the medication is oily, and it's usually a petroleum or mineral oil based type of preparation. Because of that, it's designed to stay on the ocular surface longer than your drops, your solutions, and your suspensions, and so they achieve a higher tissue concentration than those solutions and suspensions. Um, and that's because less of the drug, because of its viscosity, that's because less of that drug enters the nasal lacrimal apparatus as the normal draining process, right? Drugs are applied to the eye, they mix with your tears, and then your tears are drained through your nasal lacrimal apparatus. Because of the viscosity of your ointment, less of that is drained through the nasal lacrimal apparatus. So, again, that too allows for longer contact time compared to your solutions and your suspensions. Um, Usually, ointments, because of that, require less frequency of administration. And again, that also depends on the condition that you're treating or the severity of the condition that you're treating. But also, too, because of the increased viscosity, there is decreased systemic absorption with ointments compared to solutions and suspensions.
Yeah, I guess I'll be very honest. I never really considered much of the difference between solutions and suspensions before. Beyond those, differences in formulation and the pharmacology, are there patient-specific or owner-related factors that will influence your choice between drops or ointments?
Absolutely. Very good question. So I think the biggest thing would be compliance, right? And that applies to the patient or the client, right? So say you have a patient that maybe is rambunctious, they're really hard to give medications, putting in an eighth of an inch of a strip of an ointment can be a little bit more cumbersome for a client. Also, too, they're concerned about, are they going to damage the eye? You have this oily string of drug coming from a tube. And then getting it in the eye. Are they going to miss the eye? They end up wasting more drug from that. And so some clients, based on their pet or their comfort in applying a medication, may prefer to do an ointment or may prefer to do a solution or a suspension versus an ointment. And so also too, you may have clients that may have some physical challenges, like a lot of clients may be arthritic. And so depending on the make of the bottle or the tube, giving one versus the other may be a little bit more challenging. So we try to take that into consideration as well. We do see sometimes with drugs that are compounded from various compounding pharmacies, depending on the bottle that is used. A lot of our clients who have maybe arthritis or things like that will say that those bottles are harder. Can we try something else? So we do take that into consideration as well. Also, too, um, the frequency of the medication. So if you're dealing with a patient that maybe the severity of the ocular condition isn't that detrimental that you have to give a medication as frequently as necessary, you can go with an ointment, and so kind of cut back on the frequency of the medication and still get the appropriate treatment that's needed for the patient. So we take those in consideration as well. Because as we mentioned, ointments tend to have a longer residual or contact time versus drops. So those are things we take in consideration. For ulcers, the types of ulcers, indolent ulcers. We know that there is a challenge with the epithelium sticking down to the stroma. So in those situations, we tend to stay away from ointments because of the viscosity. We don't want that to kind of impede the epithelium from sticking down. So in those cases, we tend to move more towards solutions versus ointments in those cases.
Yeah, and I think we're going to talk a little bit about some of that as we go
Mhm.
through some of those clinical scenarios that you present in the quiz. I'll tell you, as I've gotten older, my own personal body and health and experiences have really shaped how empathetic I am towards clients. I've been having to, use some just lubricating drops because as I've gotten older, my eyes have gotten drier. And like, hitting my own eyes is sometimes difficult. And I'm wasting drops and drugs and everything. And so
Absolutely, absolutely. We get that a lot with our clients that they'll tell us, they feel like I'm wasting more drop than I am giving it. So they actually will
mhm,
prefer drops versus ointments because they feel like they
mhm,
have a little bit more wiggle room to do
mhm,
that versus the ointment is kind of like just going all over the place and, controlling how much of that you're actually wanting to give can be a little bit harder for them. So I definitely empathize. Luckily, I'm not needing any drops or my cats don't need drops right now. And hopefully that won't be the case. But yeah, this do definitely you hear their stories and you learn to empathize and
mhm.
take those things in consideration when you're trying to make
Exactly.
everybody happy.
Yeah. Another thing I don't think a lot about, and I probably should think about more when using topical eye medications, is systemic absorption of these drugs. So, could you share a few examples where systemic absorption is really important, particularly in small animals or patients that have concurrent disease?
Absolutely. I mean, and as a general rule, the drugs, the concentrations that are used are super, super low. So most instances, your systemic absorption is rather low. But as you mentioned, you're dealing with smaller animals or maybe animals that actually have a hypersensitivity to this medication that you start to see some systemic side effects associated with that with the next patient you may not. So those are definitely things to take in consideration. You were talking about your friend and colleague with Ketorolac. And so, you know, uh, we take that in consideration when we're prescribing our topical NSAIDs. And so our geriatric patients or our renal patients or our patients with comorbidities, we look at we tend to use more diclofenac versus ketorolac in for that very instance. Studies have shown like you can achieve concentrations of these drugs within the serum, and so there was a study that looked at diclofenac versus ketorolac use, and they saw that they did like endoscopy looking at the GI mucosa, and they saw that these patients who were actually receiving ketorolac showed GI lesions, GI ulcers, and they even saw that their renal values became slightly elevated. And so, those are things that we take in consideration now with our patients that we didn't so much before. I think we also take in consideration, the age of the patient and the frequency of the medication that we're going to need for that NSAID. So, that's a good example. So we tend to kind of gear more towards diclofenac because of what that study showed us versus the ketorolac. And we still use ketorolac, but again, we tend to use it more in our younger patients and in patients that maybe only need it once a day or twice a day and not so much as 3 or 4 times a day. Another example would be patients with cardiovascular conditions, such as bradycardia or hypotension. One of our glaucoma drugs that we use, timolol, is a beta blocker. And so timolol can be available by itself, or it can also be available with an additional glaucoma medication, a carbonic anhydrase inhibitor. And so what we see in some of our patients is that maybe we have a patient that we're hospitalizing after cataract surgery, and we see that their intraocular pressures are kind of spiking while they're recovering. And so we tend to kind of give them um, uh, usually we go with a beta blocker with a carbonic anhydrase mixed together. And so we tend to give that medication maybe every hour or so to kind of get their pressures down. And what we've actually seen, because they're hospitalized and they're being monitored, that it's noted that their heart rate is going down as well. And so so again, having to give that medication on a frequent schedule because you're trying to get their intraocular pressures down, you can see that systemic side effect as a result of that. So again, using that in with caution in patients that have cardiovascular disease such as bradycardia or hypertension, we take that into consideration and maybe not use a glaucoma medication with the timolol. We tend to maybe go with a carbonic anhydrase inhibitor without the beta blocker. So another example is giving topical atropine and seeing increases in heart rate as a result of that. And granted, this is a small animal topic, but also in equine medicine, we
Mhm.
use a lot of atropine. And so there's always that concern about horses developing GI stasis and colic and things like that. And so seeing that systemic effect. So those are also things that we take in consideration as well.
Yeah. I also had a specific question about, some of these prescribing some of these medications. If we have an animal with comorbid disease that's already on some oral medications, for instance, if I wanted to prescribe a topical steroid, and I had a senior dog that was already on oral NSAIDs, for osteoarthritis, which is pretty common, do I have any concerns there?
We get that question a lot. We definitely get it, with our students when they're learning about their drugs and their drug interactions, and they've learned like you don't mix, a systemic NSAID with a systemic steroid, right? And the
Mhm.
complications of GI bleeds and things like that. So when we're talking with them about the drugs that we give and the drugs that we minister, that is always a common question. And so again, it goes back to that low systemic absorption of those topical medications, and so we frequently use topical NSAIDs as well as topical steroids together. And so it's perfectly okay if a patient is on a systemic NSAID to give a topical steroid, because again, that systemic absorption is really, really low, and we don't tend to see those side effects that you would if you were giving a patient oral steroids and then you know you didn't allow that adequate washout between oral steroids and oral NSAIDs. So, and it's actually very common, especially with our cataract patients that tend to be diabetic, so they can't have systemic steroids to help with the inflammation. They tend to be on systemic NSAIDs, but again, we need to treat the inflammation in the eye after surgery. And so those patients are on topical NSAIDs as well as topical steroids in combination to their systemic NSAID or vice versa.
Yeah, yeah, that's a very good example as well. I want to jump. You talked a little bit about ulcers, and ointments, and how to choose some things like that. I had another kind of more specific question about neomycin polymyxin B bacitracin. So this is a really common ointment. It's one that I see in clinics, lots of clinics that I've worked in, and it is a good choice. My understanding, especially after taking your quiz, is that it's a pretty good choice for non-infected superficial corneal ulcers. um, I do know that there are concerns though about polymyxin B because it can occasionally cause anaphylactic reactions in cats. I've never seen that though, and I have used that ointment in cats multiple times throughout my career. So could you elaborate just a little bit on that risk and, just how you do manage a patient that does develop a severe reaction to a topical medication?
So that's a really, good question. And so I have been fortunate not to appreciate a cat having an anaphylactic reaction with the use of polymyxin B. And that question is actually, I feel like it has several layers to it when you're treating cats with corneal ulcers. So one of the things that we kind of stress is that the most common cause for corneal ulcers in cats is due to herpes. And we also know that herpes causes conjunctivitis. And studies have actually shown that cats that present with conjunctivitis will have uh, co-infection. So they will have a herpes infection in combination with chlamydia or mycoplasma, which are the most common causes for conjunctivitis in cats, other than herpes. So what we tend to know is that for us, when we're treating our cats with with an ulcer, we're going to suspect that it's herpes related. We appreciate conjunctivitis. We're also going to suspect that there is a possibility of them having mycoplasma or chlamydia present as well, based on that study. And so we know that triple antibiotic is not effective for treating chlamydia or mycoplasma. So we tend to it not be our first choice for treating cats with corneal ulcers. Um, and so that kind of like takes using triple out of the equation for us with cats as a general rule. Just to kind of muddy the water a little bit though, terramycin has been known to be the drug of choice for treating conjunctivitis, chlamydia, mycoplasma in cats for a really, really long time. But terramycin also contains polymyxin B. And so, for our internal medicine service, when we do consults with them, they will not prescribe terramycin for cats just because of that exact thing. And so for us with, we've never seen a cat, develop an anaphylactic reaction with terramycin, but we tend to now kind of shy away from that because we don't want that to happen when we know, that there have been reports of cats having reactions to the terramycin. So we tend to go more with erythromycin because, again, it is effective for treating chlamydia and mycoplasma as well. Um, so I feel like when you've got other options, it helps you kind of steer away from having the risk of developing anaphylaxis because I don't think any client, if you're prescribing terramycin and say, hey, look, there's the potential for this to happen, this is the drug of choice, I think they're going to want to say, well, what are my other options? Because if I don't have to use this, I would prefer not to. And I think we also started using more erythromycin because terramycin was always on back order. And kind of like you brought that up earlier about
Mm.
drugs being on back order. What are your other options? And so again, erythromycin was always readily available and equally effective. I think that if you were dealing with a cat that that does experience some type of reaction or hypersensitivity to it, I think it's definitely supportive therapy, fluids, diphenhydramine, monitoring them. I think it's also alerting the clients because, again, you're not going to see it. It's the clients when they go home. And so giving them that information of what to look out for should they start to develop these reactions. But again, we tend to kind of now, based on what we know and what's out there in the literature, tend to shy away from using more of the terramycin as a result of that too.
Okay.
I don't know if I did a good job at answering that
No,
question.
that was perfect. That was wonderful. Very thought out and gives us, a good rationale on why we should be choosing something else.
Mhm.
So, um, I was wondering about ointments and corneal perforations or lacerations. Should we be steering away from ointments completely in those types of cases?
So I feel that one of the things that we take in consideration is that when we're dealing with deeper ulcers, we know that those ulcers are complicated ulcers, right? So we know that there is stromal loss. We know that there is some, secondary infection that's going on. And then when we factor into the drugs that we have available, so if we were going with triple antibiotic, and, as I mentioned in the quiz, it has very poor penetration into the cornea. So it wouldn't be that line of drug that you would use because of those factors, that it is poor corneal penetration and you're using it in the face of a complicated ulcer. And so, we tend to more select those broad spectrum solutions, like fluoroquinolones, that are you're gonna have broad spectrum and they have great corneal penetration. So I think that kind of helps you kind of steer away from using ointments when you know what your ointment options are and what their spectrum of coverage is, and depending on what organisms you're treating. I think that the biggest thing as far as when you're dealing with ulcers is cytology, culture, and sensitivity, right? Starting off with the cytology to kind of help you figure out what is the best drug. First, what do I have going on in my cornea to help me select the best drug possible? Because if I'm dealing with, um, say, rods, right? Um, one medication may not be effective because it's effective for cocci, and vice versa. So that kind of helps us. What is our starting point, with how we want to approach that particular case. And I definitely feel like if you're dealing with a deep ulcer, even more reason to probably stay away from the ointments, because going back to clients and their concern of using a tube with the tips, and am I going to do more damage? And so that is definitely a concern. And also, if the risk of a perforation, or if it's actually perfed, we stay away from ointments because of the fact that those petroleums and those oil bases are very toxic to the internal structures of the eye. So again, that gives you another uh, safety net, I guess, to
Mhm.
say if you're dealing with an ulcer that is deep and it is at a risk of perforating or at a risk of progressing, to kind of just avoid using ointments just in case, they come back and it's perfed and they've been getting this ointment for however many days between their visits.
You're busy. Your CE needs to be easy to earn, and easy to track. Clinician's Brief CE is highly relevant and now more convenient than ever. Study online, from home, or on the go, and always at your own pace. Courses are race approved and designed with your busy schedule in mind. Start your next course today at cliniciansbrief.com/CE. So before the break, we talked a little bit about, those topical NSAIDs and the systemic effects that they can have, but they can affect reepithelialization on the surface of the cornea. Could you speak to that a little bit, and why we want to then avoid those in deep ulcers?
So you're talking as it relates to NSAIDs or
Yeah, the
antibiotics?
topical NSAIDs. Yeah.
Absolutely. So, we teach all the time, steroids bad for ulcers, right? And so we've kind of now started teaching, NSAIDs can potentially be bad as well in the face of an ulcer. And so if you've got other options of using a systemic NSAID, then that is probably the best way to go, because studies have shown that, NSAIDs can delay healing. They interfere with the normal repair process. Usually, this works by inhibiting COX enzymes. And so these enzymes are crucial for producing prostaglandins. And so, of course, prostaglandins are involved in inflammation and tissue repair. And so, again, if you're giving this NSAID, you're kind of impeding that or slowing that process down. And so, therefore, that can hinder migration and reepithelialization of your corneal ulcers. And so, so when we're using NSAIDs, if we need to use a topical NSAID, we're using it very judiciously. So again, very cautiously with a superficial ulcer. We tend to kind of stay away from those when we're dealing with more complex ulcers or ulcers that are infected or very deep ulcers. Um, just because of that concern of the delayed epithelialization and already dealing with a complicated ulcer, and definitely staying away from them when we're dealing with melting ulcers.
For some of those more complicated ulcers, indolent ulcers, we actually did an episode on diamond burr debridement,
Awesome.
which was so fascinating, but um, not something that I will try even after being walked through it. It's still something that I'm going to leave to someone like yourself. But we talked about contact lenses, and this is something that you had in your article too. And it's just fascinating to me. Do you think these are becoming more common in general practice? And
You,
when we're using them, sorry, I didn't
no,
mean to.
no, no.
When we're
That's
using
fine.
them, why are we using drops with them and not ointments?
So, I don't know if they are coming, if they're being used more in private practice. It's definitely something like I've given CE on indolent ulcers, and I actually encourage GPs to invest in a diamond burr, and don't be as afraid. I think when you understand, like, the when to do a diamond burr, I think it makes it a lot easier. But I definitely include in the lecture the contacts and the benefits of using contacts. So I don't know. I would be interested to know if a lot of GPs are moving towards using contacts. Um, as far as like promoting healing, how they work is that, they serve as a protective barrier, and they also help promote a moist environment because they're, retaining some of those tears underneath the contact. And so that also helps with healing, and contact studies have shown that patients that received a contact, especially when we were dealing with indolent ulcers, the healing time was much shorter. And they also saw that these patients, once you put that contact lens in, they were a lot more comfortable, compared to those that weren't receiving a corneal contact or corneal repair lens. And so that's been very beneficial. And the contact also serves as a mechanical barrier. So, against the eyelids or the third eyelids, or eyelashes irritating them. Because, again, why did they develop that indolent ulcer to begin with? Were there dystechia or trichiasis, or did they have entropion? And so, ideally, you want to get that ulcer repaired before you do any surgical correction. So, we use those contacts to kind of help keep them comfortable, but also help to alleviate whatever that irritant is that's rubbing on that cornea, creating that ulcer and helping that ulcer to heal. So yes, I use them for all types of things now, not just for indolent ulcers. So, um, and to answer your question about the ointments, with contacts, again, that kind of goes back to, it's very similar with the indolent ulcer as a general rule. Some of these contacts, they contain little um, micro openings within them to help drugs go through, or
Mhm.
um, pass through onto the corneal surface. And so, ointments can be kind of impede that from happening. And again, having that oily barrier, so also delaying reepithelialization, but also kind of delaying or not being as effective as penetrating into the cornea through the contact. And so, again, we tend to kind of stay away from ointments, for those instances as well.
Sure. That actually leads perfectly into kind of the last topic that we're going to talk about, which is eyelid abnormalities.
Okay.
Things
Yeah.
like entropion, ectropion. I always find that this is kind of this intersection between the disciplines of ophthalmology and dermatology. and I'm like, is this an eye thing or is this a skin thing? And so I just wondered, how frequently do you see these disciplines overlap, and how does that influence your diagnostic and treatment approach?
Oh my gosh, like I like this question, because sometimes it's an eye thing and a skin thing. And so I feel like, being in a teaching hospital, we definitely benefit from having, because literally, at Auburn, we have our own little communities. And so Derm is literally right next door to us. And so we just kind of walk next door and we're like, hey, I got this case. And, so there's a lot of tag teaming between Durham and Optho when it comes to these cases. So I think being in a teaching hospital is definitely has its benefits, and I feel like the patients benefit. Right, they get the best of both worlds. That skin thing that I don't feel so comfortable with handling, I can ask Derm, okay, how would I handle this? How would I manage this? And the concurrent eye thing that a case developed because of the skin thing, it's kind of very similar. So, it allows that patient to receive the best care. And so we work a lot together, and I think that that's very beneficial. And definitely being a general practitioner, you don't always have that luxury, or even being in private practice as a specialty, you may not have a dermatologist in your facility, or you may not have an ophthalmologist. And so I feel for us, we do have to figure out ways to manage those basic periocular conditions. And so again, it's pulling out that derm book and knowing your basics, skin scrapes and treating allergies. Oh my gosh, I don't know how many cases we see that have allergic conjunctivitis, but also have, blepharitis or periocular dermatitis because of their allergies, concurrently with their feet as well. And so we have to definitely be familiar with a little bit of it, but again, it's a huge help when we have derm next door and we're like, okay, this is beyond our scope. So I think that that's very beneficial.
Yeah. Yeah. In your article, you talked about a medication, natamycin, which
Hmm.
I'll be very honest, never heard of it. So I guess this is a safe topical antifungal that you can use, for periocular yeast infections. But are there alternatives for practitioners such as myself that probably don't have readily, can't readily access that particular medication?
Right. Especially, I mean, even for us, we don't, it's an antifungal, but it's not an antifungal that we use to treat our ocular fungal conditions just because of the cost. It's so expensive. And so we compound a lot of our antifungals, miconazole and voriconazole. And voriconazole is a little bit expensive too, but it is very effective with treating fungal keratitis in horses. And so it has better penetration into the cornea versus miconazole. So we do have options for treating those cases. And so in our cases that have like periocular yeast infections, and you can't use a skin or dermatological preparation of an antifungal just because of the risk of irritation, we tend to get those compounded, so that we can use those around the eyes and not have to worry about irritating the corneal surface. And so that's very helpful as well. And we also use like wipes, Chlorhex wipes, and things like that to stressing, the importance of not getting them in the eyes. And some of those also contain antifungals. But again, the biggest thing is making sure at least with the wipes, you have better control of where you're placing it and not, decrease risk of getting it directly into the eye versus medications. And definitely worrying about patients rubbing and it now introducing those dermatological medications into the eye, causing more irritation. So
Sure. And then finally, how do you go about determining when you actually do need to step in and surgically correct, specifically some of these eyelid abnormalities like ectropion, but also, like you mentioned, ectopic cilia, things like that. When should we be thinking about having these patients have surgery so that their condition isn't just recurring?
Absolutely. So definitely ectopic cilia is one that we surgically intervene all the time. Dysthecia are a little bit tricky. So the general rule, because you can have dysthecia that can be coarse, thick hairs, or you can have dysthecia that are very soft and fine. And so what we look at when we have dysthecia is if we have a corneal lesion, does that dysthecia correspond with that lesion, right? If you've got an ulcer in one part of the cornea, but your dysthecia are in another part, then are they truly contributing to that ulcer? Or if the dysthecia are really fine, are they really contributing? As far as surgical correction, ideally we try to resolve the corneal ulcer first, because it kind of is like which came first, the chicken or the egg? Was the ulcer for there first, and then now they developed the entropion because of the pain and discomfort, or was the entropion there first, and then they developed an ulcer? We tend to use topical a numbing agent, topical proparacaine, to see once we numb that cornea and we take away that pain, does the entropion correct itself or is the entropion still present? If it's still present, then we know that we're going to have to do some type of surgical intervention once we heal that ulcer. So again, the goal is let's heal the ulcer. So this is a good example of, like I was telling you, I use contact lenses besides my indolent ulcers because I can put a contact lens in this patient, allow that ulcer to heal, and then move forward with doing surgery afterwards. You can also do temporary tacking sutures as well in those cases. But, if I feel like my ulcer is going to heal in a very rapid period of time, I'll put a lens in, reassess them, and then move on with doing a permanent surgical procedure. So it's definitely trying to figure out what was the inciting cause of the ulcer. And if the entropion was, then we definitely need to do surgical intervention. If the ulcer was because of something else and then the entropion was second, will it resolve once the ulcer heals, and we won't need surgery? Or sometimes it could have been going on for so long that now it's permanently rolled in and we still may need to do some type of intervention.
So probably that's a good time to, start thinking about prepping the client, with all different scenarios so that they're not, as we work through things, they realize we might need some more definitive treatment down the line, but we just don't know yet.
Absolutely, absolutely. Discussing what's happening, and what can potentially happen, and ways that we can step in and intervene and what that may look like. So I think just keeping them informed of as things, potentially may progress. So there's no surprises. And say, okay, now we need to do surgery, and that was never discussed with them prior to, them coming in and assessing them. So we do try to keep them informed of all the potential uh, options that may need to be considered when treating their pets.
Yeah. Well, that was the end of all of my clinical questions.
Oh,
And
yes.
so that, of course, brings us to rapid fire, which I know that you are anxiously awaiting all of your would you rather questions. So if you would like to play, we'll get started with that for you.
Okay.
All right. Okay. Would you rather that your ophthalmoscope always be just like slightly out of focus, or that your tonometer was always 5 millimeters of mercury off, but you didn't know if it was high or low?
Oh my gosh. Oh, I think definitely my ophthalmoscope being slightly out of focus versus
Just
my
slightly
tonometer.
fuzzy. Okay.
Yeah,
You gotta have
yeah.
you gotta have those accurate readings.
Gotta have, especially if you don't know if they're off, high or
Yeah.
low. Definitely.
Okay. Would you rather spend an entire month managing only ophthalmic surgical cases or only medical cases?
Oh my gosh, that's a hard one. I think that I would probably go with medically managing cases versus surgically managing cases. Especially, I think if you asked me if there were horses, I definitely wouldn't want to have to manage.
Wouldn't want to do surgery.
No, but yeah, I think managing medically managing because those cases I think are the most awesome, right? If you're dealing with uveitis and and why they have uveitis, whether it's some systemic neoplastic or infectious thing, they all respond differently. Their clinical signs are all different, and so yeah,
Yep.
give me that any
Yeah.
day.
And yeah, and I agree. I actually did some mixed animal practice in my early career, and I don't care how many times you've done it or how wonderful you are. Laying down a horse is always the most stressful thing ever. So I'm
Yeah,
glad to not do that anymore.
yeah, and we've, I had a colleague, and he's no longer at Auburn, but when he and I started at the same time, and he brought to Auburn doing standing surgery procedures, and everybody's like, oh my gosh. And so now it's kind of like the norm that a lot of the
Hmm.
procedures, that they do for their equine cases. I don't see many equine cases, are mainly small, but
Hmm.
a lot of those cases are now done standing, which,
Standing.
I would do that versus having to recover
Hmm.
a patient from anesthesia.
Yep.
So,
Yep.
yeah.
If you could go back in time and repeat your residency, would you choose ophthalmology again or would you choose something different?
Oh, definitely. Definitely. I don't think I have to think twice about that. I don't know. I think it was just a calling. I always knew I wanted to specialize and I thought I wanted to do surgery. And then, I found out, well, you got to do orthopedics and soft tissue during residency. And I hated orthopedics. It was like taking puzzle pieces and putting them together. And the surgeries would last forever. And then I was like, well, maybe equine surgery. And I actually did an externship at UC Davis during my senior year, and having to be on call and having to, when you've got those colic courses coming in and getting everything together and stuff. And it just never failed when I was on call. I would get at least 2 or 3 colics, and so my whole night, I was up and then having to take care of the cases the next day. And I was like, yeah, I don't want to do that either. And then, one of our alum came and, spoke on ophtho, and then it just made sense. It clicked. And the great thing about ophtho is that it allows you to do multiple things,
Hmm.
right? It's
Yeah.
not just the eyes, which is what we teach our students and our residents all the
Hmm.
time. Like there is a body attached to that head and those eyes. And so, as I mentioned, we work with derm. So we have to know derm, we have to know internal medicine,
The
we have to
medicine.
know neurology, we have to know you know, surgery. And so I think that is why it's great. So it allows me to dabble a little bit in those things as well, but still kind of go back to ophtho, which is what I love. Since I'm a visual learner, and so it just makes sense. But I tell the students all the time that when I first went to spend time with one of the mentors, and she was doing surgery, and she said, "Have a seat," and I was like, "Oh my gosh, you guys sit down during surgeries?" And she's like, "Yeah," and I was sold. I was like, "This is for me." Your surgeries are done seated, your eye exams are done seated. This is
Yeah.
for me. So yeah, so I say that jokingly, but there is a little bit of truth behind that as well. So
Yeah.
yeah,
Absolutely.
I don't think I would be doing anything else.
Oh, I love that. Okay, I've got one more question.
Sure.
Would you rather have eyes like a chameleon that like move independently or
Mm,
eyes like an Arctic reindeer that change color with the seasons?
definitely the changing of the colors. Yeah,
Me
I
too.
like I like diversity. So, it just switches with my outfits. So,
Yeah, exactly. It's like a mood ring.
absolutely.
Then
Yes, I
everybody
would
can
take it.
tell when they shouldn't talk to me.
Yes, which would probably benefit everybody as well. Know when to stay away and when it's safe. So hands down, definitely Arctic
No,
reindeer. No doubt about it.
I think that you're fantastic to talk to, and I have
Thank
loved having
you.
this conversation. So
Thank you. Me
thank you
too.
so much for taking the time to sit down with us. Everybody at home, I encourage you to go take this quiz. It's fantastic. Like I said, I love it. I've already emailed it to colleagues, and you can find it at cliniciansbrief.com.
Thank you guys so much for having me.
Thank you for listening to Clinicians Brief, the podcast. If you enjoyed today's episode, you can find us wherever you listen to your favorite podcasts, including a video version on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcasts on our website at cliniciansbrief.com/podcasts. Or drop us a line at podcasts@instinct.vet. Clinicians Brief the podcast is an Instinct Science production, produced by Alexis Ussery and hosted by Alyssa Watson.